Good afternoon. Good afternoon. You're at panel 4. Models of death care. We're crossing that bridge. We're spanning it. Home stretch. Welcome. I am so honored to be moderating this panel today, Models of Care. I'm Sara Williams, President of Funeral Consumers Alliance. The first thing I want to say is that Dr. Aditi Sethi is stuck in North Carolina because of the hurricane. She has no power, flooding, no internet. Oh, she can't be with us virtually. I'm heartsick. She's my North Carolina connection. What we're going to do is I will meet with Aditi and we will record what would have been her time here today. I've decided she doesn't know that yet, but when her internet comes back, that's okay. We'll work it out and you will all receive that recording. So Aditi, wherever you are, we send you our best. And all right. So you know what, before I get started, I'm looking right now at Dr. Kaishauna Guidry, Dr. G. And if you notice in your program, where's her bio? I don't know. Somehow it got left out. So let me just, before I make the whole panel, Dr. G runs Mourning Medical, which is a mobile concierge practice. She went back to med school when she was 37 with 3 children at home. And now she's doing great things, including a podcast, which has the same name. Okay, Mourning Medical. All right. My panelists are now 3 women who are examples of the most compassionate caregivers and grief companions. You're going to learn about the unique settings where they operate: hospice homes, mobile hospice services, and prisons. We're going to hear how these brave models of inclusive and affordable care buck the status quo of over-treatment in medical settings and provide a new vision of how we can expand these offerings across the United States. Just to say about Aditi, her Center for Conscious Living and Dying right outside of Asheville, North Carolina, is a real work of heart. She was going to be here to share with you how this model of care helps us become more aware of the thin veil between life and death. But stay tuned because a recording will be coming your way eventually. Dr. G, you are revolutionizing hospice and palliative care with your mobile medical practice. You serve vulnerable. You serve vulnerable populations, those who are logistically unable to access healthcare services. Would you share more about your model of care?
I sure will. Thank you for having me. It's such a privilege. It really is. Thank you to Ashley, president of NIDA. Just had her on for World Death Doula Education Day and just introducing me to this opportunity. I'm so grateful and I'm learning so much. So I am a hospice physician who blossomed into CEO and founder of Mourning Medical. You'll have to listen to episode 1 of Dr. G at the Heart of Healthcare to hear the story of how the Mourning Dove came to me on my patio. You know, we've talked about all the things that I do today in healthcare. And so there are some folks who get discharged from hospice for extended prognosis. They don't die right away. They stabilize because they're getting good care at home. And maybe after a year and a half, they get discharged, and good hospice agencies have a discharge plan. So the one that I belong to, we decided that I would be their mobile physician. That's how it started. It has evolved into education and empowerment through the podcast. Dr. G at the Heart of Healthcare will be wrapping up the season on World Hospice Day, October 12th. I have 2 books, Dr. G's Hospice Pocket Guide, so that this basically is hospice eligibility in the form of stories, and I co-authored it with the death doula. And we're very proud of this because it helps people to know when it's time to get that type of care, which should be a part of the care continuum. And that's the theme here. I believe hospice is sacred work, like the daughter who had the experience for her dad. I don't know where she is. Where are you? Oh my gosh, yes. I feel like that's what we do at hospice if we're given the opportunity early enough. It's sacred work for people to have their family rituals and have a beautiful experience of love. And that's what I represent. And so I have to buck against the system. Physicians who don't refer to hospice, don't even know what we do, or people who Oh, you know what? I don't want to take all the time with these slides. This is just, I'll put them in the pre-read because this is just my little presentation of 10 slides about the late stages of life. And just think of it as a continuum of care. When seniors or people who are ill need a little more attention, maybe your grandma's been living on her own, but you guys are noticing she fell, or, you know, maybe someone needs to start going to the doctor with grandpa. When that starts on till their death, to me, is a late stages of life. It could be 2 years to 10 years. And I believe it should be a continuum. And the infographic didn't make it. It's kind of delayed. Maybe I'll send that. But that's what this is about. So I don't want to burden you with all that information. I want us to have a discussion, and I want you to be able to ask me questions as a physician. And I believe hospice is the heart of healthcare. That's why the podcast is called that. So I'm going to pass the mic.
That's okay. Lashanna, a sacred passage guides and assists passing minus passing, and I knew that, guides and assists people towards a more conscious dying experience. I've been particularly struck with your compassion for medical aid in dying and VSED patients. Can you share more about your model?
Thank you. Thank you for having me. I first want to start with, I think that it is a great privilege to have death care as we watch thousands and thousands and thousands of people not have death care. So while it may be seen as a right, it's a privilege right now as we sit here safe in this library. So that first, I had to just like share and get off of my head. Thank you for the question, Sarah. It's not just medical aid and dying and VSED people that we care for this way. It's a way that we approach death care. We approach death care from a mutual aid standpoint. For folks who don't know what mutual aid is, it's an exchange of resources so that people can have their needs met. And that's what a place to die is. The sacred passing is a whole bunch of things, but I'm going to talk just about a place to die, which is a non-medical house, or it's a non-medical network of places for people to go use medical aid in dying or VSED. Thank you. there's no cost to come to a place to die for anything. Nobody's getting paid to do the care. It's all volunteer. So it's completely outside of insurance. There's no money exchange. There's all kinds of different exchanges that we get to engage in and think about. But we work really hard to not be a part of a system that is perpetually harmful to people in the United States. I have so much more that I can say, but we can do introductions down the line.
Laura, I've seen Prison Terminal, and if you have not seen this very moving documentary, I hope you can somehow find a way to watch it.
Just email me.
Your Humane Prison Hospice Project is transforming the way incarcerated individuals die. Please share more about this model of care.
I am always happy to share more about this model of care. I don't know how much to share right now. Should I share all of it, or should we do bits and pieces? Well, I'll just start by saying that our mission at the Humane Prison Hospice Project is to revolutionize palliative care and hospice care in prisons through advocacy and training that empowers incarcerated people to be end-of-life caregivers and supportive grief companions for their peers in their community. We have a comprehensive training program that's informed by years of end-of-life experience, and importantly, informed by the lived experiences of justice-involved individuals. The goal of the comprehensive training program, which covers everything from how to use basic medical equipment or certain disease trajectories, but also trauma-informed care, cultural competency, spirituality. It's meant to strengthen communities of care, and if they don't yet exist at a particular site, to help build and nurture them in order to ensure dignity for every person as they near the end of their life. These communities of care ensure dignity, but they also, we hope, improve health outcomes and challenge important stigmas about who is deserving of good care, which the answer is everyone, but that's not always how it goes, and it's not always accessible. So we also work in the area of compassionate release, which varies state by state. Every state in the United States has some kind of compassionate release or medical parole model, except for Iowa, which is interestingly where Prison Terminal was filmed. But compassionate release is not without its obstacles. So what we're trying to do in that area is secure access to housing and care for people who are granted compassionate release. Do you want me to stop there for now, or should I just keep going? Let's have a conversation. I have much, much more to say, but I don't want to just go off a cliff here.
Well, I'm going to ask each of you, in talking to each other, what elements of the other's care models inspires you. And anybody can begin.
If I could jump in, not that I just finished talking. Lashanna mentioned mutual aid, and that's a really important aspect of our work. Our peer caregivers work alongside the healthcare staff in prisons as part of a multidisciplinary team but really importantly, fostering an environment of mutual aid and of trust in an environment that is built to be exceptionally dehumanizing. There's a critical need to provide beyond adequate, really good, compassionate care in spaces that are specifically designed to keep that out. Prisons are not built for exchanges of vulnerability or for taking care of each other. And one of our goals is to help create communities where people can care for each other the way that they want to be cared for, with their humanity at the center of that care.
I will say, Dr. G, the mobility of your program is really inspiring. Our program, people have to come to us. It's really not accessible to so many people. So the fact that you are able to go out and meet people, like you are delivering the care, and that's really inspiring. I really love learning that about your program.
Both of these ladies' programs, it was a dream. I want to have a house one day. Like, people need a place to go, because not everyone wants to have a family member die in their home. You know, every culture is different. And so the way that you create a network of resources for folks, the massage therapy that you do, going into prisons, that you keep using that term, dehumanizing, that's happening to people in the healthcare system with the best insurance. And like someone said today, take the anger and make solutions. That was you, Joel. Me too. So create solutions, because I got into trouble in residency because I was already a grown-up. So when I saw the disrespect, the marginalization, people who may have substance abuse issues or whatever, it was like, no, I'll take them. I'll talk to them. No, they're not a problem family. I got it. The healthcare system is very unkind, and it burns me up. And so I just take my little self door to door and do what I do. But, you know, you can also burn out from that. So that the driving force of what I've done is because I needed to scale the education. So where can I make a difference? I can help these folks understand this. I can create a podcast about this. I can just put it out there, and then people can pass it on. And so I just do what I can to empower people, because the system is not gonna change. And I'm an optimistic person, but it's just the truth.
So let me go back, because Lashanna, I know the people that come to A Place to Die, they're not all medical aid in dying or VSED patients. Walk us through how they get there, how they know about you. And think of the people out here who don't have the resources that in state by state. We're so far behind in getting this MAiD legislation universal.
Well, the people that come to A Place to Die are people who are making an end-of-life choice. They are folks who are choosing medical aid in dying or the VSED process. We're not a care home, so we can't really care for people long-term. I wish that we could, but we can't. People find out about us really word of mouth, because we're so really networking just through people we meet. We finally have some beautiful brochures and a couple of videos for people to watch. And so slowly building resources to let people know about us. A lot of the hospitals refer to us, like Harborview, Valley, hospices and care homes that don't allow choice will recommend that their folks come to us. All of our volunteers go through our training, which is really rooted in understanding consent and autonomy and one's own bias. We work hard to make sure that our care is as harmless as we can make it. And are people who we have to advocate hard for to get VSAD, people with MS or ALS, non-terminal illnesses that are debilitating and really shifting their whole life. If you don't have money, you can't afford care. So when people are like, just go get a new caregiver, and you're like, and then what? They stay for 2 hours. So we work with a wide range of folks. Some people come and they just really don't want to die at their house. And they have all of the means to pick a place where they would like to die. They have all kinds of choice. But we say yes to everybody. Everybody is welcome. Yeah. It's a 4-bedroom house, and if someone's family member wants to stay the night, they have a place to stay. And the other room is for our caregiver who stays overnight. People bring their pets. People have ruckusy parties. People get to do whatever drugs they want to do. Like, it's a phenomenal space for people to be like gloriously happy and real about their death. Like,
So, Dr. G, I want to know about the kind of vehicle you drive. I mean, mobile hospice, okay. Let's hear it.
I'm not that fancy, I'm regular. It's paid for, so I got this car actually in residency 2016, a black Cadillac SUV. I love Cadillacs because my pawpaw used to take me to school every day in this Cadillac with the pipe. And so it's just so endearing to have a Cadillac for me, so black Cadillac.
I'm gonna dive deeper. So, you have a patient on hospice and they don't want to go to a hospice home. Do you go every day? Do you do telehealth? I mean, tell us a little bit more about how that looks.
So let's do a little Hospice 101. And first of all, it's Hispanic Heritage Month. I'm very proud of my recent podcast. I did Hospice 101 in Spanish with a guest. I don't speak Spanish, sorry. But I had someone who does, and it's something that can be passed around so people can have the information about healthcare at home in their own language and know when it's time to access it or not be deceived to be on it when it's not appropriate. So anyway, so hospice care is for folks with a limited prognosis and meaning they have something, a chronic disease that's not curable. And the real deal about hospice, I have actually, the chapters are outlining those. So like chapter 1 is ALS. There's a story about a gentleman who has ALS. His wife is having a hard time. She doesn't really understand the team. We do Alzheimer's, cancer, HIV, end-stage renal disease. At some point, dialysis has to stop. A heart disease, the #1 cause of death in our country. There's so many people with CHF in and out of the hospital. They don't know they can have hospice care and be good. COPD. That's a big one, and stroke and coma for various reasons. And so there's 4 levels of hospice care. Most people are on routine home care, and you have the interdisciplinary team taking care of you, hospice physician, hospice RN, chaplain, someone's mom is a chaplain for hospice, and a social worker. Those are the core members, but there's other folks. The hospice aide is the MVP in my opinion. That person does the non-medical ADL support. It's awesome work. So they come in a few times a week. So hospice is not there 24 hours a day. Their caregiver, their family caregiver, or if they have means, the hired caregiver will have to do all the day-to-day. Some people do it in their home. Some people's home is in a skilled nursing facility or assisted living or memory care. But there are 4 levels of care: routine, respite care, general inpatient, that's in a hospital or skilled nursing facility, and continuous care. So sometimes when people are in a pain crisis or other type of symptom crisis, we initiate a higher level of care at home, and a nurse will be there. LVN or LPN, they may call it LPN in the state, but that's kind of the general things. But it's there, and people need to not wait until the last minute to what some call crash into hospice, right? They usually come when it's so late. This book is dedicated to Jimmy Carter because I believe he's teaching the whole country about what hospice care is, and they're actually in the process of reforming it. I had the privilege of being a part of Hospice Action Week on Capitol Hill this year with the NHPCO. It was just awesome to go advocate for change and for veterans and for telehealth. I have colleagues in New York taking the subway to do a visit. I was like, wait, the subway to do the visits, that's hard. I'm used to having a car, but telehealth is something that is a great tool for physicians because there's not a lot of us. And so we don't want to limit access for folks. So anyway, I could go on and on. Feel free to ask me any question. I'm here.
So Laura, to you, how did you film Prison Terminal in Iowa? Tell us a little bit about that process and how you use that movie in your training.
Well, I importantly did not film Prison Terminal. Our team member, Edgar Behrens, is the filmmaker. It's a longer story, but given that he's not here and I don't want to tell his story on his behalf, I will say that he spent 6 months getting to know the community there and the people working in the infirmary, sort of gaining the trust to the point that he could mosey around without it seeming like there was a camera in everyone's faces. The film's over 10 years old, but it's something that we still use as an educational tool because sadly it's still very, very relevant. And it's full circle to, has anybody seen Prison Terminal? Some of you. Herky, who was one of the leading caregivers in that hospice program, actually died just a few months ago and was able to be cared for in that program by the men he'd worked alongside and even helped to train, which I think is a really sad but important example of the empowerment that can come from creating some room for people to provide and receive the kind of care that they want. We get the best care, I think, from people who share a lived experience with us. And when we feel empowered to give and receive that kind of care that we know we're deserving of, we can then begin to rely less on institutions of power to give that care to us. And it really calls into question, do we need those at all? Do we need those systems which fail marginalized communities and vulnerable people again and again and again? Or can we begin to imagine a different system with dignity and compassion at the center of it rather than control and punishment?
That's why you're up here now, to teach and give the vision of how we all.
Well, I'll just add really quick, I don't want to give the vision. I think it's just important to ask the question and imagine what else we could do rather than what we've been told is what we have.
Oh, yes. Amen. You know, I really concur, and I think, well, first of all, everyone in here is awesome. Everyone has a vision and a mission inside of you. We're all making a difference. And I think we're all here to spark it in our own communities, in our own way, unique way. And I agree, the system is not going to fix it. We have to create the solutions and tell them what we're doing, because it's not changing. Look, I just got a text from a care management agency I'm working with. Mourning Medical, someone pointed it out to me that I'm kind of doing palliative care. And I'm like, oh, I didn't really put that label on it. I was just helping people, giving them what they need. And so if I run with that, then me and a lot of care management agencies or non-medical care agencies, there's so many, San Diego where I work, 200 of them, let's just go ahead and give the people what they need instead of having all the gaps in care that they have to navigate. I'm kind of labeling myself right now as an advocate for those navigating the late stages of life. So that's the person laying in that bed. It's the burned out caregiver who's doing the best that they can, doing what they gotta do to get stuff done. And it's the family that's there too. And so I just think we have to color outside the lines and just make stuff happen. Build bridges, that's what this is about, right?
I think specifically for your work, like that system is working just how it's made to work, right? And so like it is eliminating option even through death. And I feel like it's so important in communities that are incarcerated, like what is your death plan? What do you want so that after your body leaves this place, we can honor you with all of the things that you want, like down, like details, down to all of the, like, it doesn't matter if it's silly or simple. And that's what people don't ever get while they're incarcerated, is the opportunity to write those things down in detail. Like, we understand the system isn't gonna care or take the time, but that's the part that we need to start advocating for. I'm gonna stop.
Just to, yeah, it's not, I hear a lot from people, wow, it's a really broken system, and it's not broken. It works exactly the way it was built to work. So it's not a system that works. It's working, but it doesn't work for anyone. It's a system that needs to be done away with, abolish it. And I think part of that is imagining, I mean, what could we build that is not a prison? What could we build that is something that doesn't rely on a prison system to manage our humanity when we don't need that? We can care for each other, and we can foster growth and healing and compassion among ourselves and our communities. But I think it's really important to say that that they're deserving of is a difficult conversation. Sometimes a facilitator will start talking about the importance of self-care as someone who's a caregiver. And I think that we have to start with the conversation of self-care is something that you are deserving of. And it's also an impossible thing to have in an environment like a prison. So coming up with creative ways to honor autonomy in a place where autonomy is not considered is hard, but we're also finding that it's doable. And I love actually getting form within the Department of Corrections and how they can fill it out and how they can help their peers fill it out. And that advanced directive offers some choices, like who do you want to make decisions for you if you can't make decisions for yourself? The fact that that's even a choice, but it's not a choice that, I'll say anyone, it's not a choice that really anyone working at a prison is going to say, hey, did you know you have this option? It's just not something that happens. They're not super interested in making those options available or clear.
At this us to do better things in this death care landscape. And let now the questions come from the audience, and we're going to look up and yes.
Before questions, I just want to say, like, our model of care, A Place to Die, the network of homes, is repeatable. Like, look, we were really busy, and there are no pre-read materials from us. I'm sorry. But I can get you all of that information. And if people are interested in, like, how do I start A Place to Die in my neighborhood, hit a witch up. We can talk, and I will share everything I have. So. We are unfunded. I'll repeat that. We are unfunded, and we don't get grants very often because we provide abortion care. So funders are like, no, go. Every once in a while, people give us money, and when we don't think about it, it works. So if you know people with big pockets, send them our way. Yeah, unfunded.
It's kind of back to Mel's abundance from the gift economy. Just wait, it's coming.
If I don't think about it and just care, it works.
We have to crane our necks. Oh, there's a question. Nancy?
I'm in California. I'm in Southern California, actually all over.
Since we can do remote work, I have hospice agencies in Northern California that I am the medical director for. Like, I have a few phones in my purse. And mostly in Southern California, a couple of programs that I help. Yeah, I've worked as an employee for hospice agencies for the past 5 years. But this year is when Mourning became primary, and so I've made the agencies my client, kind of like what the death doulas are doing, where you're serving them, and I'm just bringing my expertise as a hospice physician, and I'm hospice medical director, board certified, to their agency, making sure that we're following, the quality and the regulations, and just being interested in the patients. What a thought. So yeah, California, but I do a lot of national stuff. So like, I'm online, you can find me. A lot of YouTube stuff for education to pass along. Because I don't want people to feel like in my community, they're locked into this one agency because I don't know if you've heard about the F word, fraud. There is, they talk about a lot of bad actors in hospice care and all that. So I don't focus on that. I focus on what's good and what I can do in helping people navigate it. So like I've created a podcast, how to find the best hospice agency and how to use the Medicare website. Put your zip code in there and go to 3-star and above hospices. So I'm putting the power back to the people.
Maybe I should stand. I'll tell you what. It would help if, I'll just randomly, there are presumably so many more people who want or need your care than you can support. How do you and your teammates navigate and heal burnout in your work?
I crack a lot of jokes. So my hospice team, I lean on them too. I am a doctor, but don't be telling me, oh, you're the doctor. No, I'm human. I need you. I need your support. I need to be encouraged. I love when the chaplain gives us inspiration. I have challenges too. And so just being human together, like that's what we do. And I'm an encourager. That's my spiritual gift. So I just cheer people on.
How does gender play in?
There are way more people than we can care for, and we just do our best. They fill out a form, we figure out a day, and then they come. We're working at about a VSET a month right now, and next month we have 2 at one time. So we just do the best that we can, and we also are like stretching our no muscle as far as like, no, we can't this week, but let's look at next week. And burnout is a luxury, I think. We just try to take care of each other so we can keep going.
Yeah, we have just under 2 million people incarcerated in this country, so there's a lot of people in need of care. We're just on the verge of expanding into other states. We're California-based, but we've gotten pretty far in conversations here in Washington, as well as Oregon and Michigan. I've gotten some interesting inquiries from Texas even recently. But our team is 4 people. And so as we expand, we're gonna have to really rely on leveraging local expertise and relying on the expertise of those communities to further this work. So even if you're not in California, we might need you. I don't know. My colleague Fernando and I probably scream at each other on the phone 2 or 3 times a week. Not like at each other, but just like together. And that helps. It's screaming together. It's yeah, I think just being human together, because we're so burnt out. And also, there's no option but to keep going.
We're all craning our necks to see how does gender play into the prison project? Do women work with females who are incarcerated and men with men?
Well, I'm gonna move away from the binary a little bit. So in California, we currently have 32 prisons, 2 of which are women's prisons, but not everybody who resides in those prisons identifies as male or female. So I'll just say that the residents of a prison care for their peers at that prison.
For sacred passing, have you encountered any legal or ethical challenges? What needs to be in place before a person comes to die?
We haven't encountered any legal challenges because we're all volunteers. Nobody's getting paid for anything. And so far, like we had a lawyer write our paper, and everybody that comes to the house and all their people, it's like a big group hug. It's like, you're here because you want to be, we're here because we want to be. Ethical, a ton of ethical challenges are intermixed with medical aid and dying and VSED. People are encouraged to seek out help for mental health, and then when it comes to time for them to make an end-of-life choice, that help they looked for earlier in their life is then weaponized and used against them, and their choices are eliminated. And so we fight hard for people, and are probably known as those people in a lot of spaces because we go hard in the paint for people who really deserve a choice. A lot of stuff has to be in place. I won't waste your time with the lists of things, just all of the things that you can imagine for care. We're really we're lucky that we have our rooms all set up, so we don't have to reset rooms, and we have hospital beds and all of the equipment that we provide that hospice won't provide. So like the comfort air mattress to prevent bed sores that hospice will only give you after you have a bed sore. We have them on our beds, so there's a lot of stuff we have purchased to make sure that our rooms are all set for folks. Yeah, we have, I don't know, a lot of stuff.
Let's go back to the board. Oh, there's a question about the Omega Home Network. I'm going to cover that. That is Aditi. And so when I have my one-on-one interview with her, we'll be focusing on that. So thanks for your patience. Oh, and yes, our beautiful western part of the state has just been hit hard with this hurricane. Okay. Please share that Omega Home Network is a national organization that has the model, support, and mentoring for those interested in creating social model homes, comfort care. Yeah, so that's, you can do your homework before my interview with Aditi. Let's see. We're back to prisons. Prisons have so few resources, and they are built to dehumanize. How can we help expand peer-to-peer programs?
Yeah, those are true things. I really wish I had a clear answer to this. We've been an organization for 8 years, and just last summer, we were able to pilot our first program. The prison system is not a system that's welcoming of people from the community coming in to say, hey, let me improve things around here. They're gonna just hang up on you, shut the door in your face. One of the things that I think, or that I encourage people to do, aside from just researching the landscape of their state's prison system, is figure out where the largest prisons are, the demographics of the population, what sorts of healthcare services they offer, and importantly, what sorts of programming they offer the population. It's always good to start as a volunteer in a pre-existing program. So let's say they offer a gardening program and you have a green thumb. Get in there, start making connections, get to know the community resource manager and advocate for the program that needs to be there. The other thing is, one of the things I do as far as outreach is I go to prisons. San Quentin, for example, in California has a Day of Peace every year, which is a really good opportunity for community-based organizations that offer programming to come and talk about their programming. And for a lot of reasons, we're not operating at San Quentin. I don't know that we even will because lots of California reasons. But demand from the people who live and work at that prison is meaningful. The group of caregivers at the Central California Women's Facility said, we need this, and demanded it, and secured support from the community to come in and help make it happen and sustain it. That's my not very clear answer.
Well, I say curious about Lashanna's background and how Lashanna began this work.
Email me, we could talk about it.
And let me repeat that for our virtual step down or die, or hope to see in the future.
I think I'll just keep helping. I've always been a helper. The goal is care, and we're having a large goal of seeing like everybody cared for is unrealistic to me. So I hope that we're just able to keep caring for people in really intentional, meaningful ways that don't cost us our health as well.
Yeah, I don't necessarily have huge goals. Again, everything is solution oriented, right? We see a problem and we want to fix it. And so that Spanish podcast was something where I was like, this needs to happen so my colleagues can pass it around. It's just whatever comes up. Why can't we do it? And so that's what it is.
I think I want to piggyback on that and also say like community education is the other form of that, is the more people that we get to share education and knowledge and experience with, the more people that are also doing it. And so like succession becomes irrelevant because we're all caring for each other. Can you even imagine if we all were able to care for each other? I can't.
It's like last night. In the end, we are all just walking each other home. This bridge across the death care landscape had better learn to be a little more expansive, inclusive, get more diversified, and just continue to, what can you imagine? What can you do?
Yeah, I think our funny joke at work is that our goal is that we work ourselves out of a job. And the reality is we probably won't. And just like Dr. G was saying, I mean, even if I were to wake up tomorrow and the prison system had been abolished, there would be something else that needs a solution. And short of that happening, yeah, our goal would be to work ourselves out of a job. Short of that, just keep solving the next problem that comes up, or empowering people within their own communities to be able to solve that problem and have some agency.
Okay, I want to say that we do a lot of things with joy too. Like, we're all sounding really heavy, and like there are a lot of insurmountable things, but a lot of what we integrate into our care is remembering that like there are pockets of joy along all of it. And so no matter how shitty the things may be, like we have an opportunity to be like, okay, take a breath, and then we can practice harm reduction. And so I really want to also hold that nugget of joy and let people know like it's there. And beauty. Yes.
And the joy for me, people say, how do you know you did a good job? It's when we hear the stories with the families. It's whatever they do, whatever is love for them. And we just bring in the healthcare and create the space, break down the barriers, social worker, help with spiritual care, chaplain, whatever. I just drop, the medicines and the nurses, the quarterback, and we just get out the way, and they're free to be a family. That's how I know I did a good job, so.
And that is models of care. And now we spanned the death care landscape. I want to thank each of you for all that you do every day